Good morning, everyone. Welcome to day 2 of this meeting. I think today you'll find very enjoyable as well. We're shifting topics somewhat. We spent a lot of time yesterday on ventilator-induced lung injury, on recruitment maneuvers, how do you ventilate the ARDS patient, and we're shifting today to focus more on patient-ventilator interactions, non-invasive ventilation. And in fact, our first speaker this morning is R Kakmarek. He spoke to you yesterday. He'll be talking today about non-invasive ventilation.
Thank you, Art. Well, what I would like to try to accomplish in this next half hour is to discuss those issues regarding non-invasive positive pressure ventilation that I think have an impact on success or failure. As you're well aware, we probably have more data in the form of randomized controlled trials about non-invasive ventilation than pretty much almost anything else we do in, critical respiratory care. And first thing is just to kind of scan through those indications that exist in the literature. And I've broken up, this is my organization of it, into 3 groupings based on what I perceive is the strength of the data supporting non-invasive ventilation. The top 2, I think, are pretty well established as universally as circumstances where non-invasive ventilation does seem to work quite well. Patients in acute exacerbation of their chronic obstructive lung disease and patients with acute cardiogenic pulmonary edema. As we move away from those, though the strength of the data seems to differ a little bit in its in our ability to draw conclusions. Now, there are clearly some areas, as you see listed in the second group, where there are at least 1 or 2 randomized controlled trials that highly support the use of non-invasive ventilation in that setting. Post-extubation, hypercapnic respiratory failure, hypoxemic respiratory failure, but in very specific circumstances, we have data supporting its overall use. Patients with do not intubate, do not resuscitate status, no randomized controlled trials, but a number of reasonable case series and more on the way that I think support, at least in select settings, the use of non-invasive ventilation. Acute hypercapnic respiratory failure in the neuromuscular, neurologically diseased patients. Again, no randomized controlled trials, but large amount of case series data that's been accumulated over the longest period of time in these patients. And then the ones that I think are of most issue, where there is a fair amount of controversy, and you find articles that go either way as far as whether or not non-invasive ventilation should be utilized. Post-extubation, hypoxemic respiratory failure, and hypoxemic respiratory failure in the form of acute lung injury, ARDS, I think are areas where we have to be very careful about the use of non-invasive ventilation, that the literature would imply that we may not always be doing the patient a favor by prolonging the process of non-invasive ventilation. We'll get into, as we go, some of the clinical indicators of when we should actually intubate the patient. And then asthma as the last one. And clearly we find groups that say non-invasive ventilation works great in asthma, and other groups that say, well, I can't make it work in the asthmatic patient. So I'm still kind of on the fence of where it fits in that setting. I think it is important for any of us who are in centers that do a lot of non-invasive ventilation to have a very good handle on where it fits and where it doesn't fit, and those circumstances where we need to be cautious in its application, and those circumstances where it should be considered a standard of care, as in the chronic obstructive lung disease. Now, going beyond those basic indications, non-invasive ventilation, as you are well aware, really requires that the practitioner at the bedside who is applying non-invasive ventilation approaches patients in a very different format than you would expect a patient who you're going to intubate, sedate, and mechanically ventilate invasively. As you're well aware, we rarely ever sedate these patients. In order for this to be successful in managing any patient, the patient must be cooperative with the process of non-invasive ventilation. They have to understand to a certain extent why we are applying it and what the expectations from their perspective is if this is going to work. The other thing, and I know the circumstance, I have a little difficulty with my own staff, this requires you to be extremely supportive of that patient. Remember what we're trying to do. You're trying to strap a mask to a patient's face who can't breathe, who clearly has to have, perceptually at least, in their mind that they're going to die at this point in time. And without the proper attitude of approaching that patient and spending the time dealing with the issues that the patient has concerning what we're doing, the likelihood for failure can be extremely high. You know, we've been doing a lot of non-invasive ventilation for a long time, but when we started, I could pretty much determine those shifts where we'd be successful or not based on who the individual therapist working that shift was, because you knew the attitude that they approached things with, and there were those who were more sensitive and those who were less sensitive in their interaction with patients. And this, I think, is clearly a very important issue. We allocate about 2 hours of a therapist's time to initiate non-invasive ventilation. So they have that time to sit there at the bedside if need be and interact with the patient, to stand there with the patient for a prolonged period of time during the initial application, to kind of coach them through the process to ensure that it's successful. Now, I don't mean to imply that you need that amount of time for every patient, but there clearly are patients who success or failure will be based on our interaction with the patient at the bedside. What we try to get our staff to do is to realize how difficult, as I said already, it is for a patient in extremis to accept non-invasive ventilation. As we orient new staff, we have them do non-invasive ventilation to each other. And what I try to get them to do is apply it the way I think is reasonable and apply it the way I've seen it applied. If you haven't applied it to yourself, I really think you should if you're standing at the bedside doing this in two different circumstances. Set the ventilator as I've described, very low-level PEEP, low-level ventilating pressure, and then have somebody or yourself hold the mask to your face. And then have a second set of circumstances where you go ahead and set the ventilator at 10 centimeters of CPAP or PEEP, 7 or 8 or 9 or 10 centimeters of ventilating pressure, and have somebody then strap the mask immediately to your face and be forced on that first breath to accept those high ventilating pressures. You'll find it is an incredible difference between those two circumstances. And you understand the process of non-invasive ventilation. The patient that this is being done to who doesn't has a very difficult time accepting that high pressure very rapidly. We try to get, after we've sized the mask to the patient's face, the patient, if at all possible, to hold the mask themselves, starting with very low pressures and then slowly titrating those pressures up to the level that the patient is comfortable with and that the patient accepts before we strap the mask to the patient's face. You'd be amazed at how many patients will accept non-invasive ventilation if it is applied in a slow process as opposed to the one step at the pressures that you assume are going to be the appropriate ventilating pressures for those patients. Once the patient has accepted the process, of course, slowly titrating pressures upward, we pretty much have avoided the use of very high pressures. Now, I realize there are some centers who are using over 20 centimeters of water. We rarely need a nasogastric tube in the patients we non-invasively ventilate, and I think that's because we keep ventilating pressures at 20 centimeters of water or lower for the vast majority of the patients we ventilate. Clearly, this can be an issue in those patients with hypoxemic respiratory failure, but once you exceed that 20 centimeters of water pressure with a mask, it is difficult to get patients to tolerate and accept it. So we've pretty much limited our pressures at around that point, and if it requires more, that defines a circumstance where the patient should, in our opinion, be intubated. Success or failure. easy to predict success with non-invasive ventilation. You go ahead and administer it, the patient clinically looks better, you take a blood gas, everything has gone in the correct direction, and of course the patient's status, by everybody's opinion, has improved. Failure is a little more difficult to identify and even maybe more difficult to accept as we ventilate patients non-invasively. In my opinion, I look for a two-step process in improving that patient's overall status. Before I can expect a significant change in their blood gases, I should see a change in their clinical presentation. As I apply non-invasive ventilation and it's unloading the work of breathing, unloading the work of the myocardium, I should see that expressed in changes in their vital signs. As I look at the patient, that patient who is markedly stressed before non-invasive ventilation I should see improvement in the use of accessory muscles and in their overall clinical status. When that doesn't occur, and it's coupled with a lack of improvement in blood gases, particularly if the patient has hypoxemic respiratory failure, I think we should err on the side of intubating as opposed to err on the side of continuing non-invasive ventilation. There have been a number of reports, and we have seen it ourselves, in patients in which non-invasive ventilation has been prolonged for a lengthy period of time, in those patients with hypoxemic respiratory failure. And when we finally made the decision to intubate and we discontinue the non-invasive ventilation, during the intubation process, we have had a number of arrests documented, probably because we pushed this patient to the limit of their capability of tolerating non-invasive ventilation before the decision was made to intubate, instead of intervening when we noticed that the application was not successful. And again, you'll find that in the literature. I think the most unsafe circumstance as we look at non-invasive ventilation is this type of patient, the acute lung injury, the ARDS patient who does not respond rapidly to non-invasive ventilation. That patient, I think we do the patient a better service to err on the side of intubating instead of prolonging the process. Now, from a technical perspective, I think there are many issues that we need to keep in mind with non-invasive ventilation. Obviously, we have any ventilator that's ever been manufactured, theoretically at least, could be used to apply non-invasive ventilation. In reality, we have two groups. We have these ventilators that have been designed for non-invasive ventilation, and then we have the second group, which I'll talk about, the ICU ventilators. Both, I think, have positives and negatives from an application perspective. These non-invasive ventilators as a group, because they've been designed to deal with issues of leak, are generally more responsive to patient demands and better capable of transitioning to exhalation. Now, in saying that, I'd add the caveat, as we'll see, that many of the manufacturers of ICU ventilators are now adding non-invasive modes to their ventilators to try to achieve the same ends. Difficult to know whether they have or not achieved that, because there's never been any head-to-head comparison yet in the literature that would determine that there's equivalency. These ventilators, because of their ability to compensate for leaks, I generally find work best, particularly if you're choosing to use a nasal mask. With a full face mask, it probably doesn't make a lot of difference if you get a good fitting mask. But if you are ventilating patients with a nasal mask, because of their leak compensation, they tend to do well. The problem with the non-invasive ventilators is that they've been primarily designed for use outside of the critical care area. Many of them have no monitoring, no alarms. The issue we'll talk about is CO2 rebreathing in just a second, and at the end I'll get into a discussion of your ability to achieve any reasonable FiO2 with these ventilators that don't have attached to them some gas titrating capability. As you know, invasively administering pressure support, you can have dyssynchrony, which is what this example from the literature is illustrating. Without having waveforms, when you're trying to apply this to somebody non-invasively, you have no idea whether or not you are experiencing the same set of circumstances in the patient you're managing non-invasively. In the intensive care environment for acute respiratory failure, I think it is critical for us applying non-invasive ventilation to be able to adjust the ventilator appropriately to get the feedback from monitors on how well that patient is interacting with the mechanical ventilator. Early data that was published by Neil Ferguson and Mary Gilmartin indicates that because of the design of the gas delivery systems for non-invasive ventilators, there is a potential for CO2 rebreathing. These are very low internal resistance ventilators. You have a small orifice located someplace in a single limb circuit through which exhalation normally occurs, and if PEEP level is very low, as this example showed, the probability of CO2 rebreathing can be extremely high. This is both normals and patients shown in this example. 3 sets of exhalation valve circumstances. The one in which you see the triangles where there is CO2 rebreathing was a typical small orifice in the circuit allowing for exhalation to occur. The other 2 where rebreathing was minimized was a plateau exhalation valve from one manufacturer, as well as a typical isolation exhalation valve that we would use on IPPB type machines. So with a true exhalation valve, it can be avoided, but the way the majority of these ventilators operate, simply allowing for gas to move through a fixed orifice, the probability is very high for CO2 to be rebreathed unless you maintain a PEEP level in the range of 3 to 5 centimeters of water. Now, most manufacturers today have overcome this problem by preventing you from being able to set the PEEP level at 0. Even when you set it at minimum on most of these machines, it's not 0. It's high enough to maintain a pretty brisk flow through the circuit when it's disconnected, so that as the patient is exhaling, there's enough opposing gas flow to prevent retrograde movement of their exhaled gas into that single limb circuit all the way back to the ventilator, and hopefully avoiding this. But this is something at least to keep in the back of your mind as a potential problem with these ventilators. My own opinion, if you are going to use these non-invasive ventilators to manage critically ill patients, then you should be able to monitor the patient the same way that you would monitor an intubated patient. There should be visual indicators of synchrony. They should be appropriately alarmed. You should be able to provide an adequate FiO2 to meet the patient's needs, and theoretically at least, they should be designed for use in the intensive care unit. As I said, the other alternative is this group of mechanical ventilators, which is becoming larger and larger, that group that contains a non-invasive package. Now, you have to really look very carefully at each mechanical ventilator on what that non-invasive package describes. Some of them, it simply means that certain alarms can be deactivated when non-invasive ventilation is applied. Others mean that now I can add a control on the inspiratory time during pressure support ventilation. Others actually do leak compensation. Some do it only during triggering, some do it only during cycling, others do it both during triggering and cycling. So it really requires some in-depth assessment of what that package exists on a given ventilator. I would say in general, if you use ICU ventilators, you need to avoid the use of nasal masks and any of the mask designs that include a leak port within the ventilator circuit. What you want to try to do is create a circumstance where leak is eliminated as much as possible. Not easy to do, as you're well aware, which makes, in my opinion, a little more difficult to do non-invasive ventilation with an ICU ventilator unless it has a leak compensation package, as I indicated. Cycling to exhalation is a big problem. We'll talk about that in a little bit more detail. Of course, these ventilators, monitoring and alarms and FiO2 delivery are not a problem. So as I said before, you have trade-offs as you look at these 2 sets of ventilators that you can utilize to manage these patients. In the issue of cycling to exhalation, as I said, the biggest concern is at the end of the breath, we should see during normal pressure support.
Sorry. Can you use the cursor because there's 2 screens?
Yeah, I can, but I ain't any good at it. Okay, I'll try to not click the slide forward. Here, at the end of the pressure support breath, we should not see a pressure spike above the level that you set. In other words, if the peak airway pressure is 15 centimeters of water, as the patient transitions from inspiration to expiration, I should not see that pressure increase as you see in this particular illustration. Now, this was done on a ventilator. This is actually done on a Puritan-Bennett 7200 ventilator, in which the criteria for ending pressure support is 5 liters per minute. Note the flow in which the breath ended. The flow here, as you see, is a flow of 30-some liters per minute, implying that the patient chose to begin exhalation before the ventilator criteria was actually met. The ventilator is not ready to cycle to the expiratory phase because the flow has not decreased to its criteria 5 liters per minute. As a result, the ventilator has transitioned to its secondary cycling phase, which is an increase in pressure above the set level to some specific manufacturer-defined range, maybe 2 or 3 or 5 centimeters of water. Every manufacturer does it a little bit different. The problem with that is, as Martin Tobin's group clearly defined a number of years ago, when you see that bump at the end of a pressure support or a pressure assist control breath, it means that the patient has begun the expiratory phase before the ventilator has allowed them to go into exhalation. You look at the overall activity of the abdominal muscles here, the EMG at the bottom here, and you'll note that the beginning of activity occurred midway through the positive pressure breath. So this patient started to exhale before the ventilator was ready to allow them to exhale. And it wasn't until the pressure increased to that secondary termination criteria that the ventilator actually transitioned to the expiratory phase. What you'd expect here is this patient's ventilatory drive would be increased, their respiratory rate would be greater, and a higher probability that they would have a difficult time interacting with the mechanical ventilator. Now, manufacturers of many ICU ventilators have added the ability to correct for that problem by adding, depending upon the manufacturer, expiratory cycling, expiratory sensitivity, termination criteria, termination sensitivity. In other words, the ability to change the percent of the peak flow that's necessary to terminate the breath. As a default, most manufacturers historically have used 25% of the peak flow as the criteria to end that breath. I've already told you about the Puritan-Bennett 7200, only 5 liters, a Servo 300, 5%. Those are the two that'll probably give you the most problem in transitioning with non-invasive ventilation because they have such a low flow threshold for that transition to occur. Ideally, a ventilator being used for non-invasive ventilation should allow you to adjust that percentage so that you can compensate for the level of leak that exists in a patient. And basically, to readjust that termination criteria, if I can go back, until you eliminate this particular phenomena. In other words, to increase the percentage until the ventilator terminates when the patient is ready to terminate. So in this example here, if I were to increase that percentage slowly, I would expect exhalation to move to the left in that airway pressure curve and continue to increase until that spike of airway pressure at the end of the breath was eliminated. If I was using pressure assist control, that same type of adjustment can be made by decreasing the inspiratory time. Remember, with pressure assist control, inspiration ends by time, so decreasing that time until the ventilator and the patient's inspiratory times matched, and as a result, hopefully eliminating the dysynchrony. We'll be told later on today of a new and unique way of ensuring that that occurs, but until you have an option such as that, we can use the features available on mechanical ventilators to match this as long as people are careful and look for the particular signs that imply that there is a dysynchrony between the patient and the ventilator terminating the breath. As I said, the secondary criteria is pressure every ventilator and pressure support has a third criteria, and that's time. Now, with a lot of these non-invasive packages on ventilators, pressure support is being altered. You are being allowed to set this third termination criteria so that if the patient doesn't end the breath based on flow decreasing to the termination criteria, now it'll end it based on time. So you may, as a default, set the inspiratory time in pressure support to be 1 second, or 0.8 or 0.9 seconds, so that if the breath does not end by flow decrease in that period of time, the breath will end by time, which again should improve significantly your ability to use these ICU ventilators during pressure support. And if we simply look at this example from my associate Dean Hess, how the change in termination criteria actually works. In the first example, 10%, that is when the peak flow has dropped to 10%, the ventilator cycles off. As I increase it to 25%, you can see the inspiratory time shortening. As I go to the third example and increase it to 50%, again, a further shortening of the inspiratory time. So in an excessive leak situation, you may need to have a very high percent termination criteria to ensure that the patient and the ventilator end that breath simultaneously. Now, just out of completion, you can have the opposite set of circumstances, although less likely to occur with non-invasive ventilation than with invasive ventilation, and that is that the ventilator ends the breath before the patient is ready to exhale. And you'll note on the bottom half of the screen, you can see that the termination criteria is set at 35%. If we look here at the peak flow setting as well as at the airway pressure setting, what you notice is a secondary bump in both of those. The patient has not begun exhalation to or approximately to this point in time, but the ventilator transitioned to the expiratory phase at this point in time. So the ventilator stopped applying positive pressure. The pressure dropped. The patient continued inspiring, so you see that flow dropped rapidly to zero, and then you got a secondary little spike before the patient went into the expiratory phase. As you'd expect, seeing this phenomena, you're going to have a patient who has a significant level of desynchrony. If you look at the top of this example here, simply decreasing the termination criteria, that is, dropping the percentage to a lower level that would end the breath, vastly improve that set of circumstances. So I believe this is an extremely useful control that has been added to many of the new ICU ventilators that allows you to ensure that the inspiratory time of the ventilator during pressure support and the patient can be well matched. If you have an ICU ventilator that does not have that termination criteria, it may be useful to transition to pressure assist control, which is what this is non-invasive ventilation with the Servo 900C. You can see on the one side, pressure support with tremendous desynchrony here, where the ventilator and the patient are simply very unmatched, whereas here, the patient has now been changed to pressure assist control. Remember, the gas delivery pattern in those two approaches is exactly the same. The only real difference, other than a backup rate, is that the breath ends because of time instead of ending as a result of flow decreasing. So here, matching inspiratory time of the ventilator with the patient vastly improve that desynchrony. A couple other issues just to finish up. First, humidification, I think, is a critical issue with non-invasive ventilation. All of us who began doing non-invasive ventilation well over 10 years ago now did not utilize humidifiers for the most part during non-invasive ventilation. I'm not sure why we didn't do that, but we didn't. You know, we have found that we need to add this to patients who are acutely ill, that adding a passover humidifier heated to a low level has resulted in a significant improvement in patient tolerance and avoidance of intubating patients because of accumulation of secretions in the back of the pharynx. Mask types, there are a whole herd of different masks, as you're well available, as you're well aware, both nasal and oral mask, and it is difficult to say what is the best mask for an individual patient because, as you know, your individual facial anatomies differ greatly, and a mask that fits my face well may not fit your face well. We also have 3 other interfaces, at least worldwide, that are available to do non-invasive ventilation. The full face mask here that is available from a number of companies. This Atom circuit, as you know, mostly useful for home application of either positive pressure ventilation or CPAP, and then available in Europe, not available here yet, is the helmet. Now, this is my, ranking of these 5 different approaches on different scales. You have an issue of efficacy of ventilation versus an issue of comfort as you look at these masks. And if you try all of them, what you'll find is although the helmet looks intimidating, the helmet is very comfortable. Not available in the U.S., but it is extremely comfortable. There's no pressure points on the face or the head whatsoever. The only pressure points are under the armpits. The helmet's put on, there are straps that crisscross under the arms to hold it in place. So the type of adverse reactions you're seeing are irritation, under the arms, or at least one report that I know of an embolism under the arm as a result, of the high pressure, but not the facial issues we see with other masks being applied. The problem with that is it's a large capacitor, so that it is difficult to effectively ventilate patients with the helmet. It works very well for continuous flow CPAP on patients, but in my opinion, based on both laboratory and patient data, it does not ventilate well. If I have a patient in acute respiratory failure that I'm concerned about ventilating adequately, although it is probably the most uncomfortable of all these approaches, I would choose to use the regular face mask, at least for that first 24 to 48 hours, because it does allow me to very effectively ventilate, although the comfort level I'd rate as very low from the patient's perspective. After a day or 2, easy to transition patients if they still need non-invasive ventilation to one of these other ones, frequently to a nasal mask. But in what we have available here in the U.S., I think the full face mask is always my first choice in ventilating these difficult patients. The last thing I wanted to leave you with is this data that we published now a few years ago in respiratory care, looking at the ability of these a non-invasive ventilator when we titrate FiO2 in the system to deliver to the patient an elevated FiO2. Numerous circumstances, as you see here, were evaluated. 3 expiratory ports, the typical orifice that's located up near the mask, an expiratory port in the mask itself, and an isolation valve that was put into the ventilator circuit. Different pressures, different rates, different flow rates of oxygen, and titrating oxygen into the system at 2 different locations, either into the mask itself or back here into the circuit just as it leaves the mechanical ventilator. And you see both being done in different settings. What we found overall was that, as you'd expect, the FiO2 increased as the flow of gas into the system increased. If the leak port was in the mask, the FiO2 is greatest if we added oxygen way back at the circuit, or at the ventilator, so the whole circuit would function as a reservoir. If the leak port was in the circuit or used a plateau exhalation valve, the FiO2 is greatest if it was titrated into the mask. In other words, if you had the expiratory port here, you're better off adding oxygen into the system at the patient to allow the dead space, or the space between the two, to accumulate O2 and increase the FiO2. In general, we found the FiO2 greatest if the leak port was in the mask. The other thing that I think we tend to forget is, as we adjust pressures in any of these ventilators, we adjust flow being delivered to the patient, so that the FiO2 will change every time you change either the PEEP level or the peak inspiratory pressure level. And just to finish, to give you 2 sets of circumstances where we were able to identify the highest and the lowest FiO2 that we can deliver. Now, you'll note that there's a big difference here. 22% versus 78%. And I guess what I'd like you to take home, these non-invasive ventilators that are not designed to deliver FiO2, when you titrate oxygen into the system, you have absolutely no idea what you're doing. You know, you may have 22%, you may have 70% oxygen being delivered without your ability to actually measure FiO2 in the system, which is very difficult to do, as you know, with these circuits. You really do not know where you're at. So if you have a patient who requires a high FiO2, and again, in my opinion, these non-invasive ventilators that do not have the ability to deliver oxygen is a poor choice of approach to ventilating these patients. Well, let me close there and open things up for questions. What I hope I've been able to do is define some issues that we've run into in the use of non-invasive ventilation that we've found make a difference in positive or negative results with patients. And believe me, particularly some of these technical issues, although they're small, they can have a very big impact on a patient adequately interacting with a non-invasive ventilator. Thank you.
Thanks very much, Bob. That was a terrific talk. Great summary. Questions, comments from the audience? Let me start, Bob. First of all, I agree with you that I think the key here is sort of the psychosocial, if you like, the psychological, about, you know, sort of someone at the bedside helping the patient for that first hour. That's sort of the critical time period. You had a really great discussion about the cycling off criteria, et cetera. Can you just spend a little bit of time explaining how you actually, when you actually look at that, how should someone at the bedside assess that? I mean, you gave some specifics, but when do you do that? Do you do that as soon as you put the patient on? Yeah. Oh, just a little more detail.
Yeah, I mean, the problem with us having to make that adjustment is, as you know, patient will be in one given set of clinical circumstances at the moment. And I can stand there and adjust the termination criteria to meet the patient's needs. But as soon as I walk away from the bedside, if that leak changes, my adjustment may not still meet the patient's needs. So I think once you get things started and you're to the point where you can actually sit down and look at the waveform with the patient having the mask, you know, strapped to their face and being applied, I think it's at that point that you need to start making that assessment and try to make as best an adjustment as you possibly can. The thing that works great about leak compensation is essentially leak compensation is making that adjustment for you automatically. The termination criteria that we control on the ventilator really is a step away from the ideal set of circumstances. And I would expect in the future, manufacturers, whether it's invasive or non-invasive application of positive pressure, to be able to make that adjustment on the run without our intervention. Because clearly, if I can look at the waveform and see that inspiration, the ventilator, its inspiratory time is too long, the ventilator easily should be able to make that assessment and to make the appropriate adjustment, as is done in leak compensation circumstances. So it's something that has to be done every time you interact with the patient and assess the waveforms and whether or not you have appropriate synchrony.
You also pointed out, I think, that, as we'll hear with NAVA, theoretically at least, that should be sort of the ideal for non-invasive ventilation, other than having to put a catheter down. I mean, that gets rid of exactly all that discussion. Is sort of done.
Which is why the non-invasive ventilators that are not designed for ICU use are being used in the ICU because of their ability to compensate for leaks. They don't have the other positive features that I discussed, but they do have the ability to coordinate the patient and the ventilator inspiratory time better than most ICU ventilators.
Bob, there's a question. Can we have a microphone? There's a couple questions back here.
What are your thoughts about delivering respiratory treatments while someone is being with non-invasive ventilators? Do you do it in line?
Giving aerosol treatments?
Yes.
Yeah, I think, you know, if a patient needs non-invasive ventilation, it's difficult to disconnect it and to deliver, you know, an aerosolized bronchodilator. We have to be able to interface it with the non-invasive treatment. Now, if you're using a non-invasive ventilator The ideal location is between the leak port and the mask. In order to at least, I didn't have a chance to present it, but the data that we've looked at in the laboratory, you get a greater quantity of the drug delivered if you place that nebulizer between the leak port and the mask as opposed to placing it further down in the ventilator circuit. But the quantity is greatly reduced from what you would normally expect in an intubated patient because you have leaks. You've got a continuous nebulization that is going to be leaking both during the expiratory phase and during the inspiratory phase, so you really have to increase your dose of that drug. I would basically recommend we tend to double the standard doses with non-invasive ventilation. The other thing is to, if you're going to attempt to do the aerosol delivery, is in a lot of cases, I think it's better to use an MDI. Use the adapter circuit and coordinate your actuation with the initiation of the inspiratory phase. Now, it requires careful attention by the therapist doing that, but at least you should be able to deliver most of that drug to the patient during the inspiratory phase. Bottom line, non-invasive ventilation is a poor circumstance to be able to deliver aerosolized drug therapy. I mean, we can try to do it and try to maximize the delivery, but it is not the ideal set of circumstances. In most cases, you're going to have to increase the dose that you would normally deliver to a patient who is intubated.
What if the leak port is in the mask?
If the leak port's in the mask, then I would, if you're doing continuous nebulization, then I'd move it further back in the circuit, similar to what you would do, in a invasive ventilator circuit. So you have some space to accumulate the drug before it's being delivered to the patient. But if the leak port is in the circuit, I would put it close to the mask, similar to the set of circumstances that I described for titrating oxygen into the system.
There's a question, the same row. Oh, there we go. Okay.
Another technical question. Masks. Masks are not masks.
I agree.
Our non-invasive ventilator manufacturers have done a pretty decent job with mask design. Decent job, but they all have fail-safe valves in them if you lose power. Can those masks be used effectively in a traditional invasive ventilator used for positive pressure ventilation safely?
Generally, I'd say no. And the reason I say that, those fail-safe valves always produce a leak. If you take that mask and you put it on a mannequin and you seal it with glue, the surface, so you have no leak, you will measure leaks through at least every one that we've evaluated, through that safety valve. So when you place them on an ICU ventilator, if that ICU ventilator does not have good termination criteria variability, you may actually be making the circumstance worse by using the mask with that valve in it. So on an ICU ventilator, we tend to use masks without those anti-suffocation valves in the circuit. It may work depending upon the ICU ventilator, but as a general statement, my bias is they don't work as well.
Would you recommend not to ask?
Well, there are manufacturers who produce masks that are specifically designed for non-invasive ventilation and then masks that are specifically designed for invasive ventilation. In other words, it's the same mask, except one has the anti-asphyxia valve and the other one doesn't. And those seem to be, at least we find, the ones that work best.
Someone has a mic, I believe.
Well,
Felix.
Well, hopefully it works. I just wanted to comment on a question about administration of bronchodilator therapy on BiPAP. If you're introducing several liters of flow to nebulize bronchodilation therapy, you will affect your triggering mechanism on BiPAP because it is a flow trigger device. So I think you're much better off putting in something like aerogen nebulizer or ultrasonic nebulizer in line, or something like mini hard where 2 liters you can fully nebulize instead of bleeding in 6 liters to nebulize the medication and alter the interface between the patient and the BiPAP.
Yeah, I agree. You need to be careful with that. But remember, you can titrate pretty high flows of oxygen into those systems without altering their triggering capability because they have the ability to adjust to leaks and to changes in flow in the system. But your point is well taken, that we probably need to use more efficient nebulizers with non-invasive ventilation than we would normally use with invasive ventilation because of the large volume of the drug that leaks out through the circuit.
Great. Thank you very much, Bob.
Okay.